Tonight, On Call examines the painful world of arthritis, what it is, and how to cope with it. The doctors are on call now.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Go hard! Whoa, whoa, whoa! Keep pushing.
Just your head.
Pull red handle to open bag.
Bones have many purposes that have nothing to do with movement, like protecting important organs. For example, the skull protects the brain and the ribs protect the heart and lungs. And bones also produce red cells, which carry oxygen, and white cells, which fight infection, and platelets, which stop bleeding. But it's the movement that some would call most important. Movement allows for the freedom to change location, to compete for a mate, to fight or flee, to do the activities of daily living that allows for independence or allows for our ability to help others. Movement happens because of bones and how they articulate or connect to other bones at connecting points called joints. These joints are the moving parts made to work with natural lubrication and Cushing's. But when the joints become inflamed and sick, all sorts of trouble begins, starting with a loss of movement, freedom, and independence, not to mention pain and suffering. And it's the pain in the joints that can stop that important movement. Because of the importance of the ability to move and the pain and suffering that can be related to the bones and joints that allow such movement, we have specialists of internal medicine called rheumatologists. And in the room tonight, we have someone indeed very special, Dr. Jim Engelbrecht. Coming from Regional Health System in Rapid City, Dr. Engelbrecht is a rheumatology internist who has been a frequent guest on our show. We invite you to call any and all questions about bone, muscle, and joint pain tonight. The phone number is 1-888-376-6225. Again, that number is 1-888-376-6225. So, Jim, welcome on board.
Glad to be here.
I think this the 20th or 30th time? I don't know. It's been a number of times. And a rheumatologist is what? Tell me a little bit more about that.
Rheumatology, as you mentioned in your introduction, is a subspecialty within the field of internal medicine. So it's just those people who have gone through internal medicine training who then spend a couple of years in fellowship learning more about arthritis and the arthritis-related diseases.
And you learned that? Yeah, I'm sorry.
Well, and there are boards. It's like being a cardiologist or a nephrologist or a rheumatologist. We have your own boards and things like that. So it's a subspecialty of internal medicine.
And you've been in South Dakota for how long?
Since 1980.
So practicing a few years there now, going on 31 years?
Yeah, in my 32nd year now. So yeah, been doing it for a while. I've seen an enormous change in rheumatology. I mean, it's just been phenomenal to think of the changes in one professional lifetime that we've seen.
What's for example?
Well, for example, when I was in training at the University of Utah, before I came to South Dakota, I was at the University of Utah. A large part of what we did for rheumatoid arthritis involved gold shots and a medicine called penicillamine. And of course, there weren't very many anti-inflammatory medicines, and so we were using aspirin. A lot had to do with teaching people to take 12, 14, 16 aspirin today, and then of course there was bleeding with that and all the different things. And even in the best of circumstances in those days, if you got 20, 30% response, maybe 50% of people would be able to not become disabled or something like that. That was pretty good. Now, with the new drugs and the things we do for rheumatoid arthritis, I mean, our expectation is to treat people in a way that they will remain functional and the disease under control and not progress. I mean, that's our expectation. We aren't 100%, but we're certainly far better than we were 30 years ago.
Huge difference.
Huge. Unbelievable difference.
So, and that's in rheumatoid arthritis. I mean,
Right.
you told me many years ago, when we first met actually, you were talking about rheumatoid arthritis, and you said that the life expectancy for a person with rheumatoid arthritis was?
It's significantly less than, I mean, it's hard to get a grasp on it right now because it's a changing.
But 20 years ago.
But 30 years ago, I mean, it was 10, 15 years less than the average.
Right. And so now it's changed. I mean,
it's changing. It's catching up. And lupus. You know, we talk about lupus. For example, when I was a fellow, when I was in training, medical school, University of Iowa, University of Utah, those years in the 70s up until 1980, once you had somebody diagnosed with moderately severe systemic lupus erythematosus, the 5-year survival rate was probably 20%. If you were really good.
Worse than many cancers.
Right.
20% death in 5 years.
That's 4 out of 5 died in 5 years. Okay, that's what I grew up.
And what is it now? I mean, what's happening
now? The 5-year survival rate is the same for normal population. Okay, and the 10-year survival rate is over 90% and almost the same as So it's just it's a testimony to understanding the diseases, to taking that understanding and then applying manipulation of that understanding of the immune system in a way that you can counteract the diseases to maybe not cure them, but to stop them from progressing.
Right. Give a quick word on what lupus is. I mean, a lot of people don't know what that is.
Well, lupus, it's actually systemic lupus erythematosus, and people have been around me know that what I say about lupus is if you've seen one case of lupus, you've seen one case of lupus.
Yeah.
Okay, so lupus is not one thing. It is many, many different things. It can be as simple as a simple skin rash that comes and goes. Okay, and it can be as complicated as multi-system. Heart, lungs, kidneys, brain, joints, skin, all involved at the same time.
And involved
it's your immune system basically attacking your own tissue. I mean, it's a little bit simplistic, but that's really what it is. And that is where autoimmune comes from. Auto being self, immune, immune to yourself. That's what autoimmune disease means.
And there are a lot of people with lupus out there. I mean,
if you numbers of people, probably let's just take an example of across the board demographic of say middle-aged America, say people from 35 to 60, and let's say that age group. Mm-hmm. Probably around 14 or 15% will have some early forms of osteoarthritis developing at that point. 14 or 15%, okay.
Of all those people.
Of all those people, okay. And then, but of the same group, probably 1 or 2% with rheumatoid arthritis. And
so 1 or 2% of that group will have
rheumatoid
arthritis.
That's right. 1 or 2% of the population.
And that's an autoimmune disease.
That's an autoimmune disease.
Okay.
And lupus is probably a third to a quarter of that. So we're talking about less than 1% of the population, okay, that will have lupus. But it's a significant disease. And then for example, gout is the other one we talk about, and that's probably a little higher, and that's getting worse. Okay, I mean we're getting of all things right now, gout is getting more. We're seeing more gout, so that's up to maybe 2 or 3 or 4% of the population of that age group. So,
do you have any idea? I'm going to shift before we take the next story. Do you have any idea why gout might be increasing?
I think that the studies will show pretty convincingly that it's got to do with metabolic syndrome and it's obesity related. I mean, if you track the average weights and the trends there, I mean, it really goes in parallel. And I know there are a lot of other things, and there are things within food substances, and the way we eat and the excesses in alcohol and high fructose corn syrup, and all those things play a role in it. But I think ultimately it probably comes down to obesity.
And I throw one other question. A lot of people say that this whole metabolic obesity trend in our country, this epidemic that's going, is because we don't have to physically be active anymore. That a lot of it has to do with inadequate movement. Now, some would say it's also our diets. Probably it's a combination.
Probably both. That's what I think. It's both. I mean, I think it's diet and arthritis. I mean, I think that we are basically getting eat signals every moment of the waking day. Okay,
Yeah.
Eat. I mean, it's eat commercials. It's eat signals. It's eat, and so we sit down and eat, and we don't exercise and not eat. Which, you know, I mean, I think it's both.
Great. I have a question about from a woman from Pierre who asks about rotator cuff injury.
Well, rotator cuff injury. Rotator cuff, first of all, is a combination of muscles that involve the upper arm and the upper back that come together on the top of your shoulder to allow you to, quote, rotate. The rotator cuff, okay? And so all of the shoulder motions in, out, up, a lot of it is all involved with this. And that can get injured. That can be overused. That can be injured. The rheumatologic diseases can injure that tendon sometimes, but that's usually in the face of really devastating disease that's really chewing up the joint. Most common thing would be somebody that either tears the tendon at some point in their time, they have an injury, an overuse injury when they're younger or something like that, and then as they get older it kind of wears down and frays, and it really becomes more of an orthopedic problem at that point.
There's a time to go to surgery for this. And one other question. You know, earlier we were talking, you and I, about the issue of the kinds of arthritis. And you had said when you know one person with lupus, you know one person with lupus. What about all kinds of arthritis? I mean,
you know, I think the one message that I try to communicate to groups when we speak to groups about arthritis is that arthritis is not one thing. I think in general we like to lump things together, and people always coming up to me and say, well, what's the newest thing I can do for arthritis? Well, that's like saying, what's the newest thing I can do for anemia, or, you know, why didn't my car start, or, you know, I mean, there's multiple reasons for and types of arthritis, and there are the structural issues, and the best example there of a structural issue would be, say, a repeated injury of the knee, like a football injury, right, and you damage that cartilage in your 20s or whatever, and by the time you get in your 30s or 40s, that cartilage is worn down. It's shot, and so you end up with the degenerative arthritis in one joint. That would be a very localized, specific. On the other end, you have the diseases like rheumatoid arthritis and lupus, where there's something fundamentally amiss in the immune system, okay, and something comes along at some point and triggers this, and it's like your immune system misfires, and it's seeing normal tissue as being abnormal, and it's attacking, okay? Right. And that has ramifications all through your system, and it just happens that a lot of it comes out in joint inflammation, and that's how it sort of got the arthritis label and gets into rheumatology. So big difference.
A lot of difference between arthritis. Even between the degenerative osteoarthritis groups, you know, that 15% of the elderly, maybe 20, 40, 50% of the 80-year-olds, I know, terrible arthritis, sure, and there are a variety of kinds. Some that make the knuckles look like they were the Wicked Witch of the West with all those little gnarly things, and some of them they don't have any bony thing changes, but they have pain. Some of them are more inflammatory and others are not. I mean, how do you differentiate?
Well, let's talk about the degenerative type. I mentioned the football injury, okay, so that's one joint, one knee, repeated, you know, damaged. There's another form of osteoarthritis or degenerative arthritis, which we call primary. In other words, something fundamentally goes wrong with the cartilage in certain areas of the body, and it's not necessarily weight-bearing, it's not necessarily overuse, it's just something happens. And the cartilage is not working the way it's supposed to, so the bone reacts, and when, you know, if you injure a bone, how does it react? It forms a callus, it forms a spur, it forms something. So you end up on selected joints, you get these knobbies, the things you're talking about there. Mm-hmm. You get problems in the shoulder, the hips, the knees, the low back, the disc things. And one of the hallmarks of that is that there's always these bony spurs. I tell medical students, when they look at an x-ray of arthritic hand or whatever, If it's got more bone, it's probably degenerative. If it's got less bone, it's being eaten up, it's probably rheumatoid.
Oh.
You see what I'm saying?
Yeah. So degenerative makes more.
Right.
Wow.
It's bone spurs. It's forming all these bone spurs.
Well, we touched on rheumatoid arthritis, and so I think we should talk about the fact that rheumatoid arthritis, and we have a nice interview with a person who has rheumatoid arthritis. It's obviously affecting ability to move as you would like and do the activities you would enjoy, but it also can alter your mood and your outlook on life. On Call talked with a rheumatoid arthritis sufferer to see her life experience.
I first discovered or was diagnosed with rheumatoid arthritis when I was 34 years old. I was in kind of a stressful situation. I had gotten a divorce. I was the head teacher in a middle school in my department. My father died that year, and I became president of our family operation that same time. And I'm not sure just what it was, but I think it was the combination of all those factors that really made me aware that something was wrong. Before that time, I'd had some symptoms. When I would do stressful things with my hands would get very sore and swell. But I didn't really recognize it as rheumatoid arthritis. But after that year, I went to the doctor, and sure enough, he did some blood tests and called me at school and said, I have good news and bad news. The good news, it's not cancer. The bad news, it's rheumatoid arthritis. And so from then on, I had made the attitude that I was going to whip this disease. Well, you can't whip it, but I'm living proof that you can live with it. I think every joint in my body has had a flare at some time or another. And when I first was diagnosed, it seemed like either the pain was a lot worse or I didn't have the tolerance for pain that I have now. Painful, swollen joints are probably the biggest thing you have to deal with. The second thing is the fatigue that seems to accompany it. And I think anytime you have pain, you have fatigue. And so combating being tired a lot and then not being able to sleep well at night. Rheumatoid arthritis has a way of being really nasty at night. You're not able to turn over easily, or your wrist will swell and get inflamed, and it hurts beyond, so you can't sleep, or some other joint will do that. Methotrexate I've been on now for probably 15 or more years, and it's just been a wonder drug for me. I just recently had to replace my stove, or my refrigerator and oven, and I really looked at the styles that would be easy for me to use. I have a wall oven that's at the right height so that I can take things in and out easily. It has a pull-out shelf that's on rollers, which makes it slide very well. The refrigerator, I got one with the bottom freezer and the French doors on top, which makes it easy to get things. You don't have to be stooping all the time. Things that everybody likes, but when you have painful joints, sometimes it's even easier that way. Living with rheumatoid arthritis is kind of a trial and error situation. You try it, and if it doesn't work, you back off. So we don't want to be a pest to our doctors, but at the same time, if we expect help, we need to keep them informed. You are really your own best healthcare advocate. And so staying abreast with what your treatment is and listening to your doctors, following their instructions. And then there's two other people I'd like to add to your healthcare team. And one of those is your physical therapist. I had ignored an injured knee for a year. We gave it cortisone shots, but I didn't realize that I was getting very weak with one knee until the new rheumatologist said, you need to look at physical therapy. So I've been doing that for a month now, and it's really, I think, helping. Probably one of the most important people on your health team is somebody I haven't yet mentioned yet, and that is your husband or spouse and your family. And when they understand that you're hurting today, then they pitch in and help or don't have as high expectations. And it's really good to know that you have a family that cares and that works with you. most important things in living with rheumatoid arthritis is feeling like that you're in control. And when you feel like you're in control, there's not that helplessness that can lead to depression or that woe is me, I can't do anything, because you can do things.
I can't ignore it anymore.
Well, thank you for that, Cathy. Let's talk about rheumatoid arthritis and the biologics, the new treatments. You know, the standard therapy you said was gold and penicillamine.
Years ago, yeah.
Years ago. Now, what are the standards of therapy before we add biologics? What are the treatments?
Well, the basic approaches to rheumatoid arthritis would be, you know, first of all, you want to make the diagnosis. You want to talk to people about what this means, that it's a systemic illness. You want to do the education parts. You want to reduce the inflammation. Sometimes we use a little bit of cortisone to reduce inflammation. Sometimes it's other anti-inflammatories. But very quickly, you need to talk about how do we put this disease into remission, or how do we stop it, and then you get into drugs like methotrexate and a drug called leflunomide and the sulfidine, Plaquenil. There's a number of chemical drugs. Okay,
right.
The new thing has been the biologics, and you know, people say, well, what's biologic and what's the way we used to synthesize drugs, you'd mix chemicals together and it was the chemistry set that you made the drug. Okay. Right. The biologics, it takes a biologic process to make them. So in other words, there's an imprint that uses biologic enzymes to create this molecule, so you end up creating in a biologic process. And so those drugs have been called biologics. And what those drugs do is insert themselves into the immunologic process. So in other words, there's something going on at the joint that's provoking the immune response, and this gets in between it. Either plucks it out as a monoclonal antibody would be, or it competes for a receptor or something like that. And those are called the biologic drugs, and those are the ones that have had the most profound effect on rheumatoid arthritis. And it goes back, I think the names are sort of familiar to people, you know, back, I think Remicade, Enbrel, Humira, I don't have any particular favorites, but Cimzia, Simponi, those are all what we call the anti-TNFs. You know, there's a whole host of them now. Though, so.
Right. And the only problem I have with this fabulous, wonderful advancement in science, and if I had rheumatoid arthritis and I was not responding appropriately to the methotrexate and so on, I would quickly go into that group, I'm thinking. But we don't always, do we? Do we always have to?
You know, if somebody responds to the simpler medications, the more traditional medicines, terrific.
Great.
Okay.
Okay, so, but they cost so much.
Oh, well, they cost so much. I mean, there's a reason for that, okay? I mean, these are very difficult to produce drugs. First of all, the research to get to the point where you even have something to test is very expensive. And then creating the drug to test it is expensive. And then you get enough patients that you can actually have a meaningful test. And you can't, if you're talking about a disease that progresses over anywhere from 1 to 2 to 3 years, your studies have to be that long. It's not like, well, gee, I'll give you the pill and see if your blood sugar drops.
Yeah.
Okay, this is something, do we change the outcome of this disease? Okay, so that takes a long period of time of study. And then when you finally get the approval, you go through all the regulatory hoops, the FDA get the approval, then you got to mass produce this. And here's the problem with the biologics is you have to have a sterile process, okay? This isn't the chemistry set where you can just put a bunch of stuff together and you can grind out pills. It's got to go behind, and it's got to be sterile, and you can't, you know, that's where the real expense comes in. So it's very expensive to produce.
And the bad news that you're telling me there is that it's, even when we get generics, it's not going to be cheap.
Well, you know, here again, if you're creating a relatively simple molecule, which by comparison to biologics, the regular traditional chemicals are simple molecules. It's easy to produce those generically, and you can. It's a cookie cutter approach. Then you just make a bunch of them, and the price goes way down. These are complicated molecules that take an enormous amount of skill and manufacturing and everything to make. And to make those exactly the same as what's being made is going to be very difficult. So I'm not very hopeful there's going to be generic biologics that are going to be, and they call those biosimilars.
So that's the good and the bad news. We've got lots to go. Let's do some questioning. Female from Sioux Falls, inflammatory osteoarthritis that moves from joint to joint, from fingers to knees to hips. What can I do to stop the spreading?
inflammatory osteoarthritis. Okay, now we really have a mixture here. Okay, we've had this degenerative, usually not so inflamed arthritis.
The football player
or the primary with the nodules and everything. But now in this particular person, that wants to get inflamed too. That wants to become inflamed as well. So now we're dealing with not only structural issues with the joint not functioning right because of these bone spurs and everything, but we've got inflammation to contend with. And the only defense that we have on that is really using aggressively anti-inflammatory medicines, and the medicines you hate. I know you hate these medicines.
Yeah, I do.
From aspirin to ibuprofen to naproxen to Totolac to all the generic list. If you use those diligently, aggressively, but carefully, I don't know if you can do all that diligent, carefully.
Yeah.
You can be successful in controlling that inflammation.
But you have to use them carefully because they are toxic, they raise the blood pressure, they hurt the kidney, they hurt the stomach, there's a lot of problems.
But here's the deal, okay? That list of stuff you all mentioned, that happens in less than 5% of the people that take it. 95% of the people don't have those problems with it, okay? So you have to, number one, you have to explain to people what this medicine is all about, what it's going to do, and how you're going to monitor it. And what you're going to do if they start having side effects from it.
Yep.
So,
got to be careful with them.
I know you and I have never been on the same wavelength on this.
I have a call from a male that has had years of knee that are constantly cold. Cold approaches his hips. What can it be? Knees are constantly cold. Now cold is approaching hips. What can I do? Cold. I don't get it.
Cold.
Cold hips. Cold knees.
I don't know. When you deal with unusual or atypical sensory changes,
right?
It makes me think more of a nerve problem,
right? A neuropathy of some kind.
A neuropathy or some kind of a nerve entrapment or something with the nerve, because your brain is getting the signal that's not quite meshing with. Feeling cold is not what people complain of with arthritis.
I have patients who have terribly cold feet, and you examine their feet, they're warm. They just have a sensory problem. And sometimes when you'll have a stroke on the side, they'll have 3 socks on the side where the stroke is. Both feet are the same warmth.
Yeah.
Female from Puckwana, bursitis in the hip, legs hurt from waist down. What can I do to heal it? Bursitis in the hip.
Yeah, bursitis in the hip is that the big bone. I don't have a hip model here, but the bone that you feel on your side here.
The epitrochanteric.
The
trochanter.
The greater trochanter.
Yes.
As opposed to the lesser trochanter.
Yes.
Okay.
Yes.
The greater trochanter is what sticks out there, and it's got a lot of muscle attachments, and it's got a bursa. Basically, it's just a lubricating sac. So you've got thousands of bursas in your body. Okay. And what happens there is that gets inflamed, it gets irritated, it's tender, and that will translate itself into pain in your whole leg, okay? And it's not sciatica, that's behind, okay? This is down the side, and it goes down this fibrous band on the side, and it'll make the whole leg ache. And the way you start with that is to try to interrupt that inflammation. Maybe some anti-inflammatory, but even more importantly, some cold. I spoke about cold?
Yeah.
Make your hip feel cold, okay? Take a cold pack right on that thing and start getting after that thing. Especially after you've been active, you want to put a cold pack in there before you go to bed at night. There are some stretching things. The physical therapists, we use physical therapy a lot to help us with that. When all else fails, you can do an injection there, but I really like things to heal up on their own. I don't like to be sticking needles in if I don't have to.
All right. Terri Sellers, staff occupational therapist and certified hand therapist for the Brookings Health System, walks us through some of the procedures and appliances she uses for patients.
I'm an occupational therapist, and we help in many ways. We see people that have rheumatoid or osteoarthritis, and typically they're having some pain in their hands, wrists, shoulders, sometimes elbows. They've also having trouble gripping and pinching, taking care of themselves during the day, and a lot of times they're not able to do the activities during the day they want to do, and it may be gardening or hobbies that they have that they want to be able to do and can no longer do because of the arthritis. And then we're also looking for areas that are becoming deformities. Your finger may not straighten anymore, or it may be bent. A joint may go backwards. You might have some different types of finger deformities from arthritis that we can splint and keep them from getting worse. Sometimes we have exercises that also help to improve those deformities. We do see people after they've had joints replaced due to rheumatoid arthritis. We see them after they've had surgeries on their hand due to arthritis, to help them improve their motion and strength and gradually regain some of their abilities. So I brought some equipment that we recommend for some people, and they really like it, and a lot of people are familiar with the reacher. It can pick things up off the floor for you if you can't reach it. The other way is some people will get arthritis in their shoulders. They're no longer able to lift their arms up, so they can get things in the cupboards as long as they're not too heavy with the reacher. It can help you get your shirt on if you can't lift your arms up again. And there's some other equipment that helps with that as well. This one is a stocking aid. And since you can't bend over and reach your feet, if you've got some knee or hip arthritis, you might want something like this where you can just put your sock on here. Then you drop it down to the floor and run your foot through it, and it'll put your sock on for you. Tying your shoes can be difficult. So we have some elastic laces, and a lot of times you can just get these in the store as well, and you can put these in, and then you no longer have to tie them. They stretch to get your foot in, and then they'll tighten up a little bit to hold you in, and it prevents having to tie your shoes. I bought a button hook. A lot of times we'll get deformities in our fingers from arthritis. We're no longer able to hold the button and manipulate it, so you would feed this through the buttonhole, and these are pretty small buttons. Grab the button and then pull it through, so it helps somebody that can't button. A lot of people with arthritis in their hands have trouble handwriting, and the main area that arthritis hits your hands is at the base of the thumb, this basal joint right at the bottom, and you'll notice it when you try to pinch. That's probably the primary thing that I hear about. I can't pinch anymore, I can't grip. So some of the things we'll do is we'll widen up whatever you're holding. If you make it a little bit bigger, it requires less pinch and it's less stressful on that joint. So we may add a pencil grip to a pencil. This particular pen is made specifically for thumb arthritis. It kind of fits right in your web space there. And you can write and still hold your thumb in a nice position where it's out and away and it's supported. And it's the best position to have for that joint that has arthritis down here. We want to help people. It's a lot of education, helping you find things that are going to make you more comfortable. By the age 75, I think like 75% of the population will have some form of arthritis. And certainly as we get older, we have a higher probability of getting some. But there are adjustments you can make. I think the most important thing would be that you're still able to do those activities that you want to do, that you enjoy.
Yeah. So that was great, Terri. I wanted to say we got a caller from out there in Rapid City area, and they apparently went to one of your cohorts, Dr. Jennifer May, and said, boy, did she help me. Very few problems now. Did a real fine job. So isn't that nice to hear positives?
Doesn't surprise me a bit. She's a great rheumatologist.
She is.
Great Mayo trained, terrific.
Terrific person.
Smart, yep.
And we've even had her on this show before.
You better get her back.
There you go. We have a patient who has rheumatoid arthritis and inclusion body myositis. What's that, Jim?
Well, it's there's inflammation in the muscle tissue, and for years we didn't really understand where all the inflammation came from. It was almost like an autoimmune. It is an autoimmune disease of sorts, but there is also a form now with more sophisticated microscopy over the years. We've been able to find that there's some forms of this myositis, in other words, inflammation in the muscle, where something has gotten into that muscle cell, okay, and they call it an inclusion body, and it probably is some kind of a fragment of a virus or something, but it's an inclusion body. We can't identify it, and that defines a particular kind of muscle inflammation, and that we get that from the biopsy. So if somebody comes in with an inflammatory muscle problem, okay, like polymyositis, if it's not falling exactly into the pigeonhole that it should, we might do a biopsy and looking for this inclusion body myositis, and it can be seen in conjunction with other rheumatoid things. It could be, most of the time, it's a standalone myositis.
It's not rheumatoid arthritis specifically. It's just a standalone.
No. It's in fact, it's, you know, I don't know. I've seen just a handful of probably one hand or less count of people who have had rheumatoid overlap with any kind of myositis. It's very unusual.
I see a fair amount of myositis. Probably the biggest diagnosis is polymyalgia rheumatica, which is an elderly person. They have a high SED rate, and they respond to a low dose of prednisone. It's a very refreshing disease for me because I can do something that makes a huge difference that gives them great relief. There's this other thing, polymyositis that you talked about.
Okay, well, polymyalgia rheumatica and polymyositis are two different things. Okay,
totally different.
Totally different. Polymyalgia rheumatica, literally translated, means poly, many, myalgia, muscle pain, myalgia, many muscle pain, and rheumatica, so rheumatologic. There's some mystery about it. Okay,
yeah.
It's rheumatologic. It's got some mystery.
Yeah.
So polymyalgia rheumatica is probably some kind of a inflammatory thing that happens around muscle and around joints, but it translates itself to a lot of muscle stiffness. Whereas polymyositis is actually attacking those muscle cells. Okay, it's people with polymyalgia rheumatica will present to you as tremendous stiffness and aching,
right,
usually here, whereas people with polymyositis, they don't hurt so much, but they get weak. They can't get out of the chair. They can't stand up. They can't, you know, put stuff up. So that they present in totally different ways, right, and the treatment is
totally different. Well, totally steroids.
Different. Well, but steroids is, you know, polymyositis, steroids is just the start. In polymyalgia rheumatica, it can be the start and the finish, but okay, you got the big mistake a lot of doctors make is they think that they can just treat it short term, and you got to treat it. If the natural history of polymyalgia rheumatica is average of about 24 months, so that means you're going to be on a small dose of prednisone for a period of time. You can taper it off.
That's all right. Here's a question: arachnoiditis, is it related to arthritis?
No, it's just an inflammation. That's a particular kind of inflammation around the spinal area.
The surrounding capsule around the spine has been named after a spider. It has nothing to do with spider, but it has nothing to do with rheumatic diseases. How about a 59-year-old woman walking problems in late 40s and 50s, diagnosed with spinal stenosis, degenerative disc disease from Rapid City? Are these related to it?
Yeah, well, if you, we can.
Oh, we have a
we can use a
we
model.
can use a model.
The thing is that if you get, if you see where the spinal cord is, going down through here, okay, if you end up with a lot of bone spurs sticking into that canal where that spinal cord is, okay, that starts to irritate things around there, okay, and if it gets a lot of spurs, it gets tight, and stenosis means a tightening, and so you can actually get a tightening around the spinal cord. And if you're sitting at rest or lying down, maybe not too much going on, but the minute you start moving around, all this stuff moves. Keep in mind, those nerves, that's all moving. And once that starts to move, all of a sudden, you're starting to feel pain and numbness and tingling in your legs and one thing or another, and you stop and it gets better, and one day you can walk 20 feet, and the next week you can walk 2 blocks, and then you can't walk at all, and that's spinal stenosis, and it comes from degenerative changes that develop here that tighten around the spinal cord.
And when do you know you need to do surgery? When do you need to go to an MRI?
The thing is that if you begin to have measurable neurologic deficits, in other words, changes in the strength in your legs, changes in the sensation, changes in the reflexes, all the things you do as part of a neurologic exam, if that begins to change in that situation, then it needs to be looked at.
The surgery doesn't help the pain. The surgery helps the nerve loss, is what I generally say.
Right. I think that as a general rule, if you operate for somebody for a backache, they're still going to have a backache. Okay.
Yeah.
If they have a backache along with leg pain and they're having most of their symptoms below the back into the legs,
and they're losing
that's a surgery, and they're losing. That's when the surgery makes a huge difference.
Great. After you've taken the pain medicine, tried therapy, used the special support appliances, your joints may still be deteriorating to the point where surgery is required to restore us. We visited with a patient who had traveled all of these roads.
I actually got arthritis when I was 37 years old. And the hardest part was to recognize that I had arthritis. I couldn't do a lot of things, and my arthritis was severe enough where I was bedbound for about 3 months. And you get out of the self-pity, you start to fight it. And that's where you have to get to that point where you've got to learn to fight it. And you learn to deal with your arthritis, and you cope, you adapt, but the main thing is you've got to ask others for help. And then it really hit my hands when I got a little older. The right thumb went first. And I didn't know what was going on. I just thought it was overuse, and I finally went to the doctor and to see what could be done, and then they referred me to a hand surgeon. And we tried the therapy, we did the cortisone shots. They hurt. There's no getting around it. They hurt, but they help for a little while. So what you're doing is you're buying time. I wore the soft splints during the day. I wore the hard splints at night. One of the best Christmas presents I ever got was a paraffin bath. So I did a lot of paraffin soaks at night, and if I overused my hands, I used my paraffin. I love to sew, I love to garden, and I was then yet working full time. And when I was having a hard time sewing, pinching to thread a needle, then it was time to really get serious about it. And it got to the point where they said you have to have surgery. And what they do is they go in and they actually take out the joint and they use a tendon and they make a new joint. What they didn't tell me was how much it was going to hurt afterwards. But I went to therapy afterwards. I've never seen my hand shake so hard. Just to try to do this wasn't possible. It just was a strain. But persistence, I have no problems with it. It's defeat. It really, it's almost like a personal violation. You think of yourself growing up, you're healthy, and you've been healthy all your life, and then all of a sudden you get hit with this diagnosis that there is no cure for. It's just something that you have to learn to deal with. Once you recognize the symptoms, you're just better off to see a physician, and if they indicate the surgery, don't put it off. Actually, life is too short. Enjoy it. I love to sew, and I love to garden. And those are the two things, if I had to give up, I would miss it terribly. They're my passion in life. And I surprised my grandkids. I showed them that Grandma still can climb a tree. And I did. I climbed a tree.
And she climbed a tree. What a story. Well, we've got some rapid-fire questions, Jim.
Okay.
When the caller has joint pain and it flares, she bleeds into her eyes, urinary changes, and nail bed changes. What's that?
All those things can be tied together. Inflammatory eye things can get redness in the eyes, you can get urinary tract changes, you can get nail bed changes that go with psoriatic arthritis and other kinds of things. And that's, there's a lot of different things that could be in play there, and that's just not quite enough information to really say what is that, but it sounds like something that needs to be looked into.
Okay. What about scleroderma? A little bit, sometimes eye problems with the scleroderma. Tell us about that strange disease of scleroderma.
Scleroderma, literally translated, sclero, hard, derma, skin, hard skin, was people that would develop this hard skin, contracted, very difficult to move kind of skin. That was sort of the hallmark of it, but it's a much more profound disease because it can affect the lung, it can affect the kidneys, it can have GI effects, and it unfortunately is one of those diseases that we don't have a good
the
remedy
biologics
for.
are not affecting it.
Nothing,
Wow.
There's a lot of research, but we don't have the answer on that one yet.
All right. Vermilion male, is it possible to have gout and rheumatoid arthritis at the same time?
Absolutely. It's it's not real common, but it is certainly out there. We've seen people, a lot of people that have had rheumatoid, and all of a sudden they get some kind of an inflamed joint, and it looks different than what they had before. Put a needle in it, and pull some gout crystals out, and we've got both things going on. So you just treat them both.
I have a woman, and this is terrible news. A daughter died at 17 shortly after having a diagnosis of lupus. That's just, it tells you that this is not
this is a serious disease, okay? There's we can talk about the good news being how people live longer and one thing or another, but if, there are people that get severe lupus suddenly. It surprises some people to know that the average age of onset of lupus is usually between 15 and 40, okay? This is a disease of younger people. Rheumatoid arthritis, for example, is between 25 and 50, so
very young,
and it's childhood forms, and that's a whole different show. But the thing about lupus is that it can be very elusive, and it can be a little of this, and then it's a little bit gone, and then it's a little of that, and then it's gone. And the blood tests are not perfect. Sometimes they're good, sometimes they're not. Sometimes we don't have the perfect. Just do this test, and we make the diagnosis. It's a clinical diagnosis. We try to support it with the laboratory work, but it can be very elusive, and it can be very devastating. It can just,
tough disease.
In these unfortunate circumstances where some of these diseases just drop like a ton of bricks.
Their story of the fact that this diagnosis, and many diagnoses, not just rheumatologic, I would say as a clinician, it's a clinical picture. You take the history, it's 85% taken from the history. You do your exam, you have lab, they support each other, you have to do some things, but so much is to taking a history correctly. Here's a question about 3 forms of arthritis: osteo, gout, fibromyalgia. Took Engelbrecht, now has 20% kidney function. What treatment would you recommend? Engelbrecht kidney?
It's tough. Well, I don't know why they have the reduced kidney function, but if you've got reduced kidney function, you're basically all of the anti-inflammatory are really, they're not going to. You can't take them. Okay, you'll lose the 20% you've got, and even in that situation. The little bit safer medicines like acetaminophen or Tylenol, even in that situation, it becomes a little bit questionable. So you've got to, that's a tough one. You start using some of the narcotic analgesics and some of the things like that to try to get around the pain.
What about shots to help knee pain?
Shots depends on what you're shooting, I guess. So if you have an inflamed knee, the first thing you want to do is put a needle in there and take that fluid out and see what that fluid looks like. Okay?
Make sure it's not gout, for example.
Well, it could be gout, it could be an infection, it could be anything. What you don't want to do is shoot steroid into somebody who's got an infected knee. And I think that, one of the messages we try to get to our med students and the doctors we educate and everything is when you put that needle and get that fluid out, if it doesn't look like what you expect, stop right there. Don't inject anything. Get it analyzed first before you decide. But there's also shots that you can put in knees that supplement the lubricating thing, which are okay. Some of them are better than others.
Stuff and all that. Yeah. Any pain is unpleasant. Chronic pain can be miserable. There are any number of remedies that we use to reduce pain, but there is one that may come as a bit of a surprise, as we discover in this week's essay. The word chronic means long-term and unrelenting, not something that goes away quickly. Add to this the descriptor pain, and you have chronic pain, which happens to too many people in too many guises. There is chronic low back pain, recurrent migraine headaches, the post-herpetic pain following shingles, the neuropathic foot pain of diabetes, and the body-wide muscle pain and focal tenderness of fibromyalgia, to name a few. Recently, I learned about another chronic pain diagnosis called regional sympathetic dystrophy, which can sometimes follow a complex orthopedic surgery. The bad news is that once a person has one of these chronic pain syndromes, it is very difficult to be rid of it, like an unwanted guest who never wants to leave. Surgery is too often no help and sometimes makes it worse. And too frequently, our medicines are not enough help, even when accelerated up to narcotics, muscle relaxers, or anti-seizure drugs. Even injections of steroids are invasive, expensive, and if overused, can be harmful. And in the end, too many people still suffer, and pain takes control and shuts them down. Most helpful is to understand that the cause, or at least the worsening, of such chronic pain can be from not enough movement. If a joint or muscle is not used regularly, it barks and bites when called upon to move. which in turn results in less movement, more pain, even less movement, and so on. This cascade, if unstopped, can result in severe disability. Thus the reason they say use it or lose it. Add to this more time to dwell on the pain, often a sense of hopelessness, the addiction potential of pain medicines, and it becomes a very vicious cycle. Paradoxically, very often the most effective way to bring someone out of spiraling and progressive chronic pain is to get them moving. The answer is usually not more surgery or more pain medicines. Of course, each case is different, and sometimes severe inflammation needs to be rested, but often carefully moving through stiffness and causing some pain can be the answer. As they say, you sometimes have to pain to gain. One patient told me his best help was to accept the fact that he has to live with pain and get on with life. Studies show that return to function, although not easy, is the key to rehabilitation. This comes with physical occupational therapy, rehab programs, and mostly an internal drive to get better, get moving, accept the pain, move on. Chronic pain doesn't have to mean progressive immobility, disability, and hopelessness. We should remember to accept the pain when we have to, and when advised by the doctor, to move those muscles. Use it or lose it. Any comment about use it or lose it, Jim?
No, I agree. I give up. I agree.
Okay.
You've convinced me.
All right. That's important. We have a caller, 92-year-old woman. Is she too old for a knee replacement?
The oldest person that I've ever had in all the years of practice that got knee replacements had his first knee done when he was about 92 or so, and his second knee when he was 94, lived to be 98. Never regretted 1 minute of having his knees replaced. So it depends on how you are, okay? I mean, if you're a functional, healthy person and the knee is holding you back, I don't care if you're 92 or 52 or whatever, you need to get some help with it.
Okay.
So.
Let's talk about osteoporosis quickly before we run out of time. I know that I've been espousing making sure that we get enough vitamin D. I see a lot of people with osteoporosis. Maybe it's not osteoporosis, it could be osteomalacia. And they've lost a lot of bone in light of not enough D in their life. A lot of people low D. What do you think about that?
You know, I think I've been on the D kick for 30 years. That was my area of research interest when I was a fellow. So, I know that D is a problem. We've really harped on D for many, many years, and I think D, making sure that you get adequate D, and you don't have to have super D levels, but just adequate D levels, so you have reasonable levels.
And what's a reasonable
level? You can measure. There's various assays, but if your number is somewhere between 30 or 40 on the bottom end and say 70 on the top end, if you're in the middle there somewhere, 50, 40, 50, 30, 40, 50, 60, that's fine. You just want to make sure it's not in single digits, and you don't need to have it higher than that. You can get overstimulated with D, and there's hypervitaminous D problems. But in this latitude, you can't. I tell patients somewhat jokingly, you can stand outside naked in the wintertime in South Dakota and you won't make any D because the sun's just not high enough. You just can't make D. That's it. So you got to check the level. You got to get the D, and that really is the foundation of getting adequate treatment for osteoporosis.
What D? We're pretty safe in recommending for everybody 2,000, are we not?
I say 2,000 is fine, especially in the winter months. If you get a lot of sun, you're out in the garden a lot in the summer and things like that, and using sunscreen, but picking up a tan, you're getting some color in your skin and things like that. You don't need to maybe take 2,000 in the summertime, but certainly from October to March, 2,000 a day would be reasonable.
Yep. All right. So I wanted to say that a program note, we are producing a special edition of On Call that addresses something that's been in the news lately. Unfortunately, in the news a lot, actually. That's the child abuse and sexual predators issue. Please join us on Tuesday, not this Thursday, but Tuesday, December 13th at 7 p.m. for the On-Call Special Edition, Child Abuse and Sexual Predators. We will have special guests, interviews, and information to help protect your family from those criminal activities, or what can you do if you suspect child abuse is occurring in someone you know. Please join us. Make a note of the special day. That's Tuesday, December the 13th, right here on South Dakota Public Television. Jim? We sure appreciate you being on the show.
So would you like me to sum up a little bit?
Well,
here?
would you sum up, Jim?
All right. I appreciate being here too. And I think what you do with the show is terrific. And I know at the end of the show you always like to say, well, sum up something in rheumatology. I want to sum up something in health in general. And it's something that you know that I feel strongly about, and that's healthcare literacy. And I think people taking
20 seconds.
Taking part in their own health care, understanding what's going on is very important. A show like On Call is very important for that. There's no axe to grind, there's no bias. So I think people need to call, they can request shows, they need to thank the sponsors, and they need to focus on call.
Thank you so much, Jim. Thanks so much for being here, and thank you for watching. Until next time, stay healthy, people.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.